Chelsea, a GYN surgery nurse who works with me. All right. So Dr. Shu told me the history, and you had a biopsy that showed a uterine cancer, endometrial cancer. And I know he spoke with you about it. I'm just going to kind of review, and then we'll go from there.
Record this.
Yes, yeah. And I'm going to take notes on this, and you'll also be able to keep this. So basically, this lining of the uterus is called the endometrium. So they did a biopsy.
Yes.
And that showed an endometrial cancer. And what they can tell from the biopsy is the grade of the tumor. Tumor, cancer, we kind of use them interchangeably, okay?
What do you mean, doctor?
Oh, sometimes I say tumor, but I'm talking about the cancer.
All right.
Okay.
How is it? Is it a tumor there, or?
Yeah, so what we can see is just this lining gets thickened. So usually after menopause, that should be very thin, just a few millimeters. And in your ultrasound, it was 10 millimeters, so, twice the size it can be.
Is it all over the wall or a certain area of it?
Usually we can't tell. All it does is cause a thickening. So we don't know, we'll talk about treatment. The standard of care is a hysterectomy. So usually on the uterus specimen, that's when we find out the exact measurements. But what we know from the grade, they grade that on a scale 1, 2, or 3. Yours is grade 2. So usually 1 and 2 are both considered low grade. So that's good. So So typically these grow slowly, and a lot of the times surgery is all you need. Okay, but we won't know that until surgery. So then the purpose of surgery, so that's the standard of care treatment. Meaning this is when we have a diagnosis of endometrial cancer, we know what works best and gives you the best survival, and that's surgery. There are alternatives that it can be treated medically, but they're not as good and not the standard. Okay. But if you said, I don't want my uterus out under any circumstances, then we could talk about the alternatives. Otherwise, I'll concentrate on the standard of care. Is that what you would like? Okay. So the purpose of surgery is to both remove the cancer and for staging. And staging is to see if the cancer has spread.
Yes.
Okay? I know this is about. Like I said, it's nobody likes to hear cancer, but this is one. It's low grade, very good results. Okay, all right. So we just need to take one step at a time. But I know it's always it's difficult to hear that you have cancer. All right. So staging. So part of the staging, when we put you to sleep for surgery, one of the first things we do is inject a green dye into the cervix called indocyanine green. And we've come a long way with how we manage uterine cancer. We used to do a big up and down incision. Now we can do it through small incisions, laparoscopically or robotically. So it's robotic assisted. The first thing we move actually are those the sentinel lymph nodes. So I talked to you about the dye that gets injected. That goes through the lymphatic system. We can usually actually trace the path it takes. And then it comes to a lymph node that we call the sentinel lymph nodes. So the first lymph node along those paths, we look for one on the right side and one on the left side, and we remove those. Okay? The purpose of the significance of those is if the cancer is not in those lymph nodes, the chances of it being in other lymph nodes is exceedingly small. Okay? So we remove those and we send them to our pathology lab. And they let us know, do they have cancer or no cancer.
Sorry, doctor, you said you removed the
sentinel lymph nodes.
So you removed them entirely?
Yes. Yep. Not all of them. Usually it's just, one or a cluster on each side.
Oh, okay.
It used to be that before we had this technology, we actually had to remove all the lymph nodes, and we would get several, sometimes 10, 20 lymph nodes on one side. And then it caused more side effects that way. But now, with this system using the dye and the mapping, the sentinel lymph node mapping, we can get all the information we need by just removing one or two lymph nodes. And then then we don't need to do as extensive a dissection. Now, if for some reason the dye, sometimes, the lymphatics system, you can't predict. But this isn't a perfect system. Sometimes we don't 100% of the time find just one lymph node. And in that case, then we will have to remove more. But typically, we can, I'd say over 90% of the time, 95%, we're able to map both lymph nodes, and then we're just removing those.
Is there any side effects of removing them all?
Removing them all. So, increases your risk of developing swelling in the legs, what's called lymphedema. That's one of them. Sometimes you can, because we're removing the lymph nodes and they serve a function, they kind of get that lymphatic fluid and kind of process it. So sometimes you can get a buildup, a cyst in that develops in that area called a lymphocele. But again, very low risk of that if we're just removing one lymph node. And then even if we need to, on one side, for instance, remove all of them, the risk of side effects is about 10 to 15%. So still the majority do very well. Good question. So remove those lymph nodes first.
Thank you for explaining everything. Thank you.
Welcome.
Appreciate it.
Then, of course, we remove the uterus, cervix, tubes, and ovaries. With endometrial cancer or uterine cancer, it is one that's hormonally driven. So even though you're after menopause, the standard is to remove the ovaries as well. Okay. So all this comes out, and we also send that to pathology. Then we actually remove it vaginally, so that's how we can just do small incisions up here, because everything comes out the vaginal canal. And then we put stitches way up at the top of the vagina where you can't see. And that is how it gets repaired there. So overall, very safe surgery. So it's robotic assisted removal of the sentinel lymph nodes and hysterectomy, which refers to removal of the uterus, and then both tubes and ovaries. You're actually able to go home the same day. It's a long day. They bring you in a couple hours before the surgery. There's a couple hours recovery afterwards, but you're able to leave the hospital the same day. These 5 incisions, this one, the second from the right, will be the one that's the most tender as you recover. And that's because that's the one where my assistant is putting instruments in and out. It's just a little bit larger than the others, and so we have to close it with a deep stitch underneath. And that's why it is a little more tender than the others. It's not that there's anything wrong with that one. It always just hurts a little bit more than the others. Risks of surgery include the risk of bleeding. Are you okay with a blood transfusion if necessary? Okay. And we only only if you lose a lot of blood, then we replace it. But typically, you just lose an ounce or so of blood, very low blood loss with it done through this, okay? But we have to mention anything that can happen, even if it's very low risk. Other low risk is infection. So once you're asleep, we give you antibiotics through your IV to decrease that risk. And even lower risk of injury to other organs. And I always highlight the urinary tract because things are very confined in the pelvis. So the bladder sits right on top of the uterus. We have to move the bladder out of the way slightly in order to do a hysterectomy. So that's in that less than 1%. There's a chance of injury to the bladder or the ureters, which are these tubes that carry the urine from the kidney down to the bladder. Okay. But overall, very safe. We're going to take good care of you.
Thank you very much. Appreciate it.
For after the surgery, the pain, is it too much I can handle?
Yeah, usually people do very well. They'll monitor you in recovery. There's 2 stages of recovery. You'll also, sorry, they really want me. 1 second.